because I thought the whole area of HER2 positive breast cancer is actually the breakthrough advances that have occurred in the area of trastuzumab and anti-HER2 antibodies and the advent of antibody drug combinations, etc., etc. However, this is not actually the case. There has been a bunch of advances in local therapy as well that haven't actually translated to our practice in South Africa yet. And as she nicely put to us, these things do take time, and it's important for the international crowd to make the mistakes. To make the mistakes and set the precedents on how we should proceed and how we should incorporate the changes into our practice. Other advantage of having her talk beforehand is that I don't have to go through all the studies that she's gone through already. So this talk that I'm going to give gives a little bit of a summary of things that went before. Because I think it's the things that went before, because it's important to understand the foundations so that we can understand the advances upon which they are built. So, so basically back to the basics, the biology of HER2, it is the second member of the human epidermal growth factor receptor family, and it comprises 4 genes, which codes for different receptors, and it does play a key role in cooperating with other members of the HER2 family, and this stimulates cell growth and differentiation and survival, which in fact is absolutely normal because we want breasts to grow and develop. We describe overexpression as Noor put it nicely, if there's more than 2 gene copies, and this is generally associated with breast cancer. So the HER2 proto-oncogene, or as we know it as HER2-neu or CR2 that we see on the report, it actually encodes for the transmembrane HER2 protein and is on chromosome 17 Q12 according to his talk, according to the studies that I read, 1721. But nevertheless, HER2 transmembrane protein is expressed in various cells and tissue types, excluding those of hematopoietic origin, and it is frequently overexpressed in a number of cancers, which makes a lot of sense because if it's responsible for cell growth, differentiation, and survival, you have a multiple of these transmembrane proteins. Obviously, there's going to be an overstimulation of the cell, overstimulation of cell growth, differentiation, and ultimately prolonged survival, which is all the features of a cancer. And the most common mechanism for this to occur, as per his talk as well, is amplification of the HER2 gene. Amplification of the HER2 gene was actually first identified in breast cancer and then was subsequently identified in the ovarian cancer, and this was identified in the 1980s, 1990s, and most recently it's actually been diagnosed in or identified in other quite aggressive types of cancers like lung cancer, stomach cancers, and oral cancers as well. So we're seeing it in aggressive cancers. It has an intracellular domain, which is the tyrosine kinase domain. And the tyrosine kinase, the reason why I mention it is because it's a very strong activator of transduction to the nucleus, which then stimulates nuclear gene activation and ultimately cell division. The HER2 gene amplification is seen in about 15 to 20% of all breast cancers, and gene amplification is also associated with more aggressive tumor behavior and a poorer prognosis. This is seen translates to a shorter overall survival rate, which is approximately, the 5-year survival of patients who have HER2 positive breast cancers tends to be about 68%, and those with the overall survival of HER2 negative breast cancers tends to be around 87%. The significant shorter time to relapse, HER2 positive breast cancers tend to relapse within the first 5 years, whereas HER2 negative breast cancers tend to progress after 10 years, etc. We see them disease progression late. So the Herceptin-like antibodies, or the new drugs like newer trastuzumab, the one that we know so commonly, blocks the recycling of the HER2, which ultimately leads to its cell destruction. Now, HER2 has this lovely ability, or if it's overexpressed, to recycle itself. It goes outside the cell, it lives in the lysosome, which allows it to have prolonged stimulation of the nucleus. And therefore, if we prolonged stimulation of the nucleus means prolonged stimulation for nuclear cell division and all of those things, which ultimately leads to increase in the number of cells. So the whole point of the antibodies is to stop this whole process, which means it destroys the lysosomal state. And once it destroys the lysosomal state, the entire HER2 transmembrane protein basically dissolves. When there's no HER2, it means other members of the family, of the HER2 family, are not activated. And if they're not activated, it means there's a weaker signal for cell growth, and this slows down the malignant growth of the tumor. Okay, so what is the role of surgery in the management of HER2 breast cancer? And this actually, in our practice, hasn't really changed that much. That's why I thought this talk was going to be extremely difficult. So for patients who have HER2 positive breast cancer, surgery can actually be regarded as a standard part of therapy at all stages, including stage 4. I'll qualify this later. The question really is, when should surgery be done? And should upfront chemo be given versus upfront surgery? And this decision is informed by the clinical stage of the disease. So for those who forgot their staging of disease, we're going to start with stage 1. Breast cancer, which is defined basically as tumors that are smaller than 2 centimeters and are node negative. And for this, standard of care internationally and locally is basically upfront surgery. And the data does suggest that a de-escalated treatment approach has very good long-term outcomes, and that therapy upfront with chemo and trastuzumab, or the current protocols that are in place for neoadjuvant treatment of disease, will actually result in overtreatment. And I'm going to quote the trials that have already been quoted. The AP trial, which looks at adjuvant paclitaxel and trastuzumab in stage 1 patients that were only treated in the adjuvant setting, and that they actually have a 97.5% 7-year recurrence interval, which is actually perfectly adequate. Do we want better? Should we really be aiming for absolutely 100% recurrence-free interval? Is that really going to be worth it? And is that 2.5% going to make a major difference, or worth it to treat the number of patients? And the ATTEMPT trial, which looks at a year of only adjuvant trastuzumab emtansine versus chemotherapy, which also suggests that they have a 3-year disease-free survival of 98%, which is, again, perfectly adequate, meaning that if we do give neoadjuvant treatment, we'll most likely be overtreating a lot of patients. So, upfront surgery and our surgical options, and this is in the recommendations based this was published in May 2021, and we can upfront surgery is acceptable, and it can come in the form of breast conservation therapy via tumor excision or oncoplastic tumor excision, or mastectomy with or without reconstruction, which may be immediate or delayed, and sentinel lymph node biopsies. Remember, these patients are clinically node negative. This is generally followed by paclitaxel for 12 weeks plus 18 cycles of trastuzumab, as we've mentioned before. And if the tumor is found to be more than 2 centimeters, you can add chemotherapy. And if there's node negative, you can add pertuzumab if it's available in your setting. This is a pictorial depiction. So if the big one study that supports the addition of The pertuzumab was the affinity study, and there's further studies being done that suggests that trastuzumab and emtansine is actually better than trastuzumab alone, as already has been discussed. So, moving on to stage 2 and stage 3 disease, or the early breast cancers, but not the very early ones. Okay, and these are defined as basically tumors that are larger than 2 centimeters and are node positive. And for these, the generally accepted treatment protocol is upfront neoadjuvant therapy, and it's given even internationally to about 17 to 40% of patients with these tumors. And it has the advantage of downstaging the tumor, and therefore we can offer patients smaller or less aggressive surgery. And it also allows us to evaluate the response to therapy and the effectiveness of the neoadjuvant therapy. And this allows us to tailor the adjuvant therapy a little bit better. So we start off with neoadjuvant therapy. This is usually given as a taxane-based treatment, plus international guidelines say pertuzumab and trastuzumab. And this was supported by the Neosphere trial, which was aggressively called out by Dr. Irene. And this then later we, after neoadjuvant treatment, we'll operate the patient, get a pathological result at surgery, and we'll evaluate whether the patient has a total pathological response. And this is associated with improved survival endpoints. This has been seen in the pooled analysis that was done at the CT Neo breast cancer trial. And for those patients who do have a pathological complete response, if they were given trastuzumab combination, we don't stop there. We continue that treatment for another 18 cycles. And if they still have invasive residual disease, then the Catherine trial basically set the pathway for giving trastuzumab and emtansine in the adjuvant phase. That seems to be the better drug. So what is the role of surgery here, and what are our surgical options? So the big role of surgery here is in the post-neoadjuvant phase would be to remove the tumor, which is what the patient actually wants. Be rid of this cancer, and that will also give us the information about the pathological staging of the disease, which is basically what was the response to the preoperative treatment or the neoadjuvant treatment that they've had, and then this will allow us to tailor the treatment in the adjuvant setting. And this again can be done as breast conservation surgery, which can come in the form of a tumor excision or oncoplastic tumor excision, or mastectomy with or without reconstruction, which can be immediate or delayed. And then we can give for the lymph nodes, we can either offer the patient a sentinel lymph node biopsy or axillary lymph node clearance. And this is all supported again by the recommendations. And there are a couple of studies that are being done at the moment, looking at how we can downscale treatment in the neoadjuvant setting. I'm not going to go through that. It's been just now I get assaulted by Irene again. And there's a couple of studies, except as we've mentioned, the Destiny breast 03 study that has been already, results have already come out showing that trastuzumab deruxtecan is actually shows exceptionally good results and is far better than trastuzumab and emtansine, and should actually be given in the adjuvant setting if there is residual disease. And then for those patients with hormone receptor positive cancers, you can add neratinib and plus endocrine therapy if you have that available in your setting for extended therapy. It has been shown to, in a small percentage of patients, to reduce the progression and free survival. So I thought, okay, let me look in the world if people are just offering surgery and not offering this toxic, nasty, awful chemotherapy stuffs and all this awful HER2 crap. And then they have to put in ports and get drips all the time. And unfortunately, I came out with literally deadly squat. I don't know if these patients are receiving surgery on its own and then going to receive other alternative therapies, we're not hearing about it, or that's not being written up. Right. So I thought, okay, if that's what's happening, maybe let's see if the oncologists can get by without the surgeons. But it turns out they are trying quite a bit to get rid of us, because there's a lot of work coming out internationally on the outcomes without surgery post neoadjuvant treatment. And this was all started by studies that were done at the MD Anderson Cancer Center by this guy called Cura et al. He started this whole thing. And this whole thing is about how in these patients with a pathological complete response, can we downstage surgery even more? Or can we downstage treatment even more? So basically, eliminate surgery. So the big questions before you eliminate the surgeon from the whole surgical protocol of treating the patient, there are four main questions that have to guide our thinking. And the first question is, how do we evaluate what outcome measures do we look at to analyze the diagnostic tools that we are currently using to evaluate the pathological complete response? So basically, what do we look at to see if the core needle biopsy or the MRI is effective in diagnosing a pathological complete response? And then the second question is, what are the best diagnostic tools or combination of tools that need to be used to identify a pathological complete response? And more importantly, in this question that you have to ask, when you do these tests to identify the patients with a pathological complete response, is the morbidity of the test that you are doing less than the morbidity of the surgery that you would have done in its place? And I'll talk about that shortly. And the third question you have to ask is, what are the oncological consequences for missed residual disease? And in saying so, can we adopt a watch and wait strategy? Is it safe? Is it going to be tolerable for the patient? The fourth question that we need to ask is, how do we develop trials that answer these questions? So the question number one, it seems that not many, the study that I looked at that wrote this whole question about, or the review article that brought this to light, he said that a good evaluator of outcome measures to evaluate the tools that we are using to evaluate the pathological complete responses in terms of sensitivity and specificity. And for sensitivity, we should look at false negative rate. So basically, how good is the core needle biopsy at telling us that if it comes back negative, is it really negative, or is it maybe? And rather, we're not seeing we're missing individual cells. And the second one, which they couldn't actually put a finger on, is how to evaluate specificity. So they suggested that we look at multiple subgroups or develop combinations of predictors that can evaluate patients that will have a low probability of having a false negative result. But that answer still needs to come. The question two, the diagnostic tools that we can use to evaluate for residual disease. So most of us will think, okay, we're using mammograms and ultrasound, maybe that's like old school. MRI and PET is even better. But actually, in the studies that have been done evaluating MRI and PET scan in evaluating residual disease, they've actually had suboptimal results. So they're not as good at identifying residual disease. What about minimally invasive image-guided biopsies? That seems to be the standard in most of the studies, like vacuum-assisted biopsies or core biopsies, either stereotactic or ultrasound guided. And that seems to be what most of the studies that are doing this are using. But there are issues, and the issues with all of these tests are the sensitivity and specificities of the biopsy can depend on the tumor biology. So basically, for example, luminal tumors, so the HER2 positive, luminal A and B tumors tend to have a more heterogeneous response to neoadjuvant treatment, which means they leave behind little scattered foci of cells, which are more difficult to biopsy, therefore making it more difficult to identify residual disease. Whereas the triple negatives and the HER2 positive type of breast cancers tend to have tumor shrinkage or tumor collapse, which happens early on in the disease, and therefore it's a little bit easier to identify residual disease in those patients. And then initial and residual imaging abnormalities. So on initial imaging, basically you see this big tumor sitting there, and then how do you compare that later? Because our subsequent imaging on, for example, mammogram doesn't show a tumor there, but on ultrasound it does. How do you interpret that? And the size of the residual defect. And then additionally, we need to standardize the biopsy techniques. For example, do we all do ultrasound guided biopsies, or should we all do stereotactic guided biopsies? What is the core needle size? Should we use a big needle? Should we use a small needle? Which one is better? And how many cores? And this was the question that I'm going to go back to the morbidity of the disease, because a lot of the tests suggest 6 to 12 cores should be taken to get an adequate result. Taking a patient 6 to 12 times while they are awake under local anesthetic, that's freaking painful. Then I'd rather do a smaller operation or oncoplastic PE or tumor excision under general anesthetic. And the consequences, question 3, the consequences of missed residual disease. Now, the first thing is, why do we want to even eliminate breast cancer surgery? I mean, it's not like rectal cancer and esophagus cancer. There, the morbidity of surgery is massive. I mean, if you eliminate surgery from rectal, I mean, if you do rectal, an APR resection on a patient, the patient ends up with a lifetime stoma. That's besides the mortality risk in esophagus cancer. But breast cancer surgery doesn't have that kind of morbidity. It's generally well tolerated. Apparently, studies show that up to 20% of patients are unhappy with their aesthetic outcome. This actually translates to quality of life. And that's why they want to eliminate breast cancer surgery. So the question that we have to ask ourselves is this a first world problem? Is that really translating to what we see here? Next question is, can we adopt a watch and wait approach? And the thing is, I mean, the evidence out there, what is the evidence on outcomes for missed residual invasive disease? And what outcomes are they looking at? Are they looking at overall survival, disease-free survival? What adjuvant treatment are they giving? So there's a lot of questions that still need to be answered in this area. But the fear is clear. If you miss residual disease, it results in more relapses, and based on old studies, a worsened survival. And the consequences depend, I suppose, to a greater extent on whether the residual disease is either in situ disease, which gives us a little bit more time and can be addressed by adjuvant treatment to a certain degree, or is it invasive disease? Is there lymphovascular invasion, which relates to a higher risk of metastases, and the quantity of residual disease? So are you biopsying the wrong site? You're leaving behind a 2 by 2 centimeter tumor that you didn't notice. I mean, that's not going to be cleared up by adjuvant treatment. And then how do we follow up these patients? If you declare the patient having a pathologically complete response, what imaging tools are we going to use? Are we going to use just simple mammogram and ultrasound? Are you going to add MRI? And how often are you going to add the MRI? Are you going to do it every year? Are you going to do it 6 monthly? And if you're going to do it every 6 months, is medical aid going to cover the cost? Or can our government institutes, etc., cover the cost. So it all translates. Question 4. How do we create clinical trials to answer these questions? Luckily, they put this algorithm in there, because if they had to give it to me to think out, I would have come up with a very, very different picture. So first of all, we have to identify the cohort of patients that will have the highest probability of having a pathological complete response. So we have inclusion-exclusion criteria, then randomize them to having surgery and not having breast surgery. So basically allow them to adopt a watch and wait approach. You have to chat to your patient, because they have to accept the consequences. So it has to be based on patient preferences and if they appreciate being randomized. And then they have to get the standard adjuvant treatment protocols that are in place. And then finally, we have to have primary outcome, look at the same primary outcome, and that should be local regrowth, and secondary outcomes, looking at overall survival, etc. And then we all have to use the same follow-up techniques. So the same imaging, have access to the same imaging, etc. And then be able to have protocols in place for if they do have recurrence, regrowth of the tumors. So at the very least, I thought this was this was a beautiful picture showing the evolution of breast surgery. Why do we have, as surgeons, such a big block against being excluded from the whole protocol? And I mean, we should have seen this coming. From 1894 to where we are today, we're slowly doing smaller. I mean, there's been greater de-escalation of treatment. We were doing radical mastectomies, then modified radical mastectomies. Then we started doing TEs. So why not do no surgery? Doesn't that sound nice? And then finally, where the most, I think, controversy exists is in stage 4 or metastatic breast cancer. And just to give you a little bit of background, the development of HER2 targeted therapies did alter the natural course of HER2 positive metastatic breast cancer by prolonging the survival of these patients. This is Irene. Again, I thank you for coming before me, because as she nicely put it, if you have the money and to spend, and if you have access to the disease, to the drugs that are available, basically metastatic breast cancer can just become another chronic disease. And with time, it probably will. And the treatment that we institute is basically dependent on when the metastasis is noted. Is it de novo or more than 12 months after the adjuvant treatment has been given? Or is it being, has the metastases been noted while the patient is being treated with curative intent, so the early progresses? And then whether the patient has central nervous system metastases, because as we know, HER2 positive breast cancers, a third of patients will be diagnosed with brain mets. Ironically, their survival is better, probably due to the better CNS controlled by the anti-HER2 agents. And best case scenario is that the initial treatment can be done by neurosurgery and radiation, so local control first. So basically, if you diagnosed after or de novo, after the adjuvant treatment is complete, or de novo with metastatic disease, there's a whole bunch of trials that Irene has gone through that suggest first line, second line, third line, and fourth line treatments. But it's absolutely beautiful about what your options are now. And that's just a pictorial depiction. I mean, if you take 6 months of each of those, there's basically 3 years in there of treatment that you can try. Okay. Then patients who were being treated with curative intent, basically the early progresses. So Destiny Breast came back, and we're hoping that we'll get access to the Deroxtican very soon. But if we don't, then if the patient hasn't been treated with pertuzumab, which most of our patients probably haven't, then you can give them trastuzumab, chemotherapy, and pertuzumab. And then additional therapy options as if you have them available. Again, these are first line, second line, third line therapy protocols that have been discussed if you have CNS disease. And what is the role? So looking at the European guidelines, local regional treatment of the primary tumor in the absence of symptomatic local disease does not lead to an overall survival benefit and is thus not routinely recommended. And this was from last year. But surgery of the primary tumor can be considered if there's bone-only metastases, if the tumor is hormone receptor positive, if it's a HER2 negative tumor, if the patients are under 55, if the patient has oligometastases, and a good response to initial systemic therapy. This is who they suggest should get treatment in the surgical treatment in the metastatic setting. However, studies have been published, American studies have been published, 2016 and ongoing. It seems to be an ongoing question, where this study looked at 1,063 patients that were treated with trastuzumab and olipitamab, and they were diagnosed with stage 4 de novo disease. And surgery was associated with a long-term survival of more than 5 years. And the study specifically states that surgical management and resection of the metastatic site and surgical resection of the primary breast tumor were associated with long-term survival benefits, more than 5 years. So there is, in certain areas, advantages can be noted. Further, other studies, also American study, looked at 3,231 patients, 1,130 of them had surgery, and these patients were also treated with chemotherapy and immunotherapy, or combinations of therapy, including endocrine and radiation. They were also diagnosed with stage 4 de novo disease, and surgery again was associated with a better overall survival if you operated in the primary breast tumor. So there are other factors that are also, they looked at, that are also associated with improved overall survival, but surgery should not be kicked out of the protocols in stage 4 disease. So when looking at it, the verdict is still out. And in recent years, most patients with HER2 positive breast cancers have been treated with systemic therapy, which could include combinations of chemotherapy, targeted therapy, endocrine therapy, radiation therapy, and surgery. And this does improve their long-term outcomes. And this does create a place for surgery, surgical management in the metastatic setting. The studies that were done before, they did show that there isn't a benefit or overall survival benefit for surgery in the metastatic studies. They're old and don't give us a very good idea of whether those patients have been treated with anti-HER2 therapies, etc. So in conclusion, the role of surgery in HER2 positive breast cancer has not changed significantly yet. MDT discussion should be mandatory given the advances in all the aspects of therapy, and additional studies still need to be done to identify the combination of minimally invasive investigations that can accurately diagnose or identify patients that have had a pathological complete response to neoadjuvant treatment, and if it is safe to omit surgery in these patients altogether, and conversely, which patients are likely to have residual disease and thus will ultimately need surgery. There are certain indicators that we can look at, like the grade of the tumor, the presence of DCIS on biopsy, the amount of disease present, or the burden of disease in the breast, and the presence of classifications on mammogram, etc. And then obviously additional studies need to be done in the area of metastatic breast cancer to accurately understand which patients will indeed benefit from local regional therapy, and further understand which, identify which of those, and if they do, which of those patients will benefit the most. Thank you.
Thank you, Fatima. I notice a silence in the audience. Are you now all stom geslaan?
I feel so threatened. I think I must start doing my speak to. These surgeons will take me over. Yeah, so it's.
I think what we're looking at here is, unfortunately, we have no good way of really identifying the patients that will have a pathologically complete response. And that investigation still needs to be described, be it non-invasive, be it invasive. So that is the vexing problem for the neoadjuvant setting. In the metastatic setting, there will always be the whiff of selection bias, because those patients who are doing well will have a better survival anyway. And it is a question that I don't expect an answer anytime soon. And the older members of the audience, and I won't look at anybody in particular, they will know that this problem has dogged us for decades already. So luckily, we are in a position that most women with breast cancer will have, or not most, that is paternalistic and politically incorrect. Many of our patients appreciate the surgical options that we can offer them, because otherwise they would have to pay for them. And we will have an exact way of determining, or the most exact way of determining whether there's any residual disease is still surgery. And this is unfortunately so, and will stay, I think, for a couple of years still. What do you say, Fatima?
Yes, 100%. I mean, I don't think things are going to change in the near future. Even the studies that are being done, they still have to identify how to create those trials to evaluate the safety of pathological complete response. And then after that, put those into clinical trials to evaluate, if we can actually use that as our standard of therapy.
I think
it's decades away.
I think it should be recommended to everybody in the audience to visit next year's European Breast Cancer meeting. That would be, is it Barcelona again? EBCC, Rika, do you know? I don't know. It's the European Breast Cancer Conference, because last time before COVID, there were quite a couple of interesting presentations to exactly that topic, and perhaps we will get more insights then. Studies are ongoing in that, but I don't see a quick resolution to the problem.
I don't think it's ever going to be possible to say that we have complete response. No pathologist, how good, will be able to exclude a single cell. Whether you haven't got it in the specimen of the neoadjuvant, or you've got a big specimen and you've got a slice how many 100,000 slices. So this is the reality. I think radiotherapy is indicated due to that uncertainty.
Hey, we're going to listen to you just now.
Yeah, but I see we can spend time trying to get that, or you can use your admin.
You're dissing here the pathologist on top of everything else.
I think basically all the studies mention that having the complete specimen and having these core biopsies, etc., you're going to have inaccuracies. No test is going to be 100% even, as you mentioned. But the whole thing is, are the tests that we have available to identify a pathological complete response without the invasive surgery as good as surgery?
Yeah.
And that question has not yet been answered. And the thing is, even when it is answered, I think it will differ from institution to institution, because ultimately the parameters have been set for margins, etc., what is acceptable for good surgery. But how do you set up those parameters for a good biopsy? I mean, it depends on who's doing the sauna, or where is the stereotactic, who's doing the mammogram, how good is the stereotactic core biopsy, or who's doing the vacuum assisted biopsy. There's a lot more human error that can happen in the biopsy or the minimally invasive process. And I think that's where the problem.
I think we still haven't conquered another problem that you alluded to. Does it actually matter? And we've, in the course of sentinel node biopsy, we actually learned that residual malignant cells, they don't matter. But is that true also for the primary tumor? And it's an issue that I tread very carefully on. So does it really matter?
See, it doesn't matter at all. I think, you have a false negative rate of up to 10%, and that's what the sentinel lymph node trials suggested. However, when you start exceeding that 10%, then they started seeing that there is a big problem. And there's more false negative, a higher false negative rate. Then the test is not adequate enough.
Does it matter?
Does it matter?
No.
Yeah.
I think if you have TDM1, it does matter because you only need a few cells to get benefit of that drug. And I mean, we don't routinely just give TDM1 in the adjuvant setting, so you actually need to know, not so much if you have a tumor, but you just have any residual. So, for me, I think it does matter.
Is that to motivate for the drug, or is that to?
No, the trial actually showed how so you just need a few cells to get benefit, and the benefit was qualified for PR.
Yeah, to try to qualify for the drug. If it's a drug to everyone, then it doesn't matter.
No, but they saw that.
Yeah, but
they saw the
toxicity,
advantage
so
of
it does matter. You only want to give it to those people who are going to benefit.
Yeah, the toxicity is not nothing. And it's a year of very expensive treatment.
Could I ask a very basic pathological surgical question that doesn't just apply to HER2 positive disease, but applies to surgery post neoadjuvant chemotherapy, and that is really basically which marker do you find the best to insert prior to surgery, prior to treatment, so that you can find your tumor bed afterwards? And what do you do when you can't find the flipping marker? Does that happen to you? Do you assume then that you're in the wrong place, or do you assume that your marker's fallen out and wafted off somewhere else?
I think if you ask 10 surgeons, 10 different surgeons who don't work in the same practice, that question, then you're going to get 10 different answers, because there's lots of markers. I mean, just in this last week, I think there were 2 reps who came to me with a different marker. The one has it's like gives you like a radar kind of, it works on radar, so you can tell how far you are from the marker. And then there's the Sentimag that it has a tracer that you can put in. Then there's the basic ones that you look for with ultrasound, whether like a donut or a cross or a heart or whatever. So there's lots of different markers. So that's the first thing. And so it depends on what you are comfortable with. If you're good at ultrasound and you're happy using that technique, then go for it. But there's people who find other techniques better and they are more comfortable with that. So it's generally a surgical surgeon preference. And then to answer the next question was, what do you do if it goes missing or if you can't find it? If you can't find it, then you go back to your initial basically your initial imaging, your initial examination. Where was the tumor? Where was the tumor on that examination? You look for it again. You can either cancel the procedure and try using a hook wire or something different method of localizing the tumor, or if it's possible, or you can offer the patient, if they still want a tumor excision, you can. I mean, if they're hard and fast about the tumor excision, you can take your chances. You can also offer them a mastectomy. So range.
I think we have a couple of surgeons here who would like to comment. Etienne.
Yeah, I think the most important thing that I always stress very carefully if I go and give talks on this is that number one is you need to have a system that works the same way every time. So you have to have a policy in place of saying this is our policy, my policy, whatever, and you can work with 3 or 4 different oncologists. You have to sit together and you have to say, this is how we are going to manage our patients. First thing is, you need to decide when the marker gets placed. So in our unit, we decided every patient that gets biopsy will have a marker there. Because I also want to see in 6 months or 8 months' time, if the patient comes back tumor, is it in the same spot? Was it something we missed, or is it something whatever? So when is the marker placed? At the very latest, the marker should be placed within the first 2 or 3 cycles of chemotherapy, because that's often when cancers can disappear completely. So that's the first thing. every single patient that gets neoadjuvant chemotherapy should have a marker placed. There should, even if you're planning a mastectomy, you can ask Noor about how difficult it is. So the issue about multifocal becomes an issue of saying, so then we'll normally place a marker in, if they let's say they're 2 or 3 or 4, we'll normally, in a sort of anything that's significant in size, we'll put sometimes 2 or 3 markers into those. It is important for the pathologist to be able to find the tumor bed nicely. And I think, so at the very least, we would mark the largest one, but frequently we'll do, the 2 or 3 largest ones that we think about. And if we do see a couple of spots, we will usually biopsy all of them. So that, because we have patients that have 3 different tumor subtypes in one breast. And I need to know what that is. Okay, so I think the first issue is every patient needs a marker if they're going to have neoadjuvant therapy. Number 2 is which marker you use. You need to, again, that depends on how you're going to do. So if you do MRI, for example, to monitor response, you can't use SCOUT and MAC, SEED and stuff like that because they're going to cause MRI artifacts. So then you need to use a marker that is MRI compatible.
But sometimes you don't know whether you're going to do an MRI with your host.
So for that purpose, for example, we don't use those because for the odd occasion that we want to use MRI, it makes that difficult. Okay. And secondly, because we place markers for every patient, cost is an issue. You can't put a marker that is 2,000 or 3,000 rand more per marker in every patient, and they walk around with a little radar marker forever. Okay. So I think these are all things that as a unit or as an MDT team, you have to decide and you have to then stick to that.
And what do you base that on? Sorry.
What is that policy based on? Is there prospective evidence on how to do this, or is this all just we've got to make a best case scenario?
The answer is there's no prospective evidence to say this marker will do better than that. So I think for me it is about what is going to give us the best quality to have a 0 defect outcome. So everything we do is put in place so that we can ensure that in 20 years' time, I've never had a marker go missing or not find a marker. For example, it is because every patient gets managed in exactly the same way. They have a marker at the time of biopsy. If they don't have one, they get one placed early in the chemotherapy. Every patient will have a pre-operative imaging to ensure where that marker is. If the marker is going to be localized, they will have stereotactic plus ultrasound to confirm the tip there. Every patient has a specimen mammography to ensure that what you were looking for is being taken out. And you might say, yes, it doesn't matter in 90, but it matters in that 1% of patients. I have a recent patient that was referred to me where a mastectomy was done after neoadjuvant chemotherapy. They couldn't find tumor. And then 8 months down the line, mammogram comes back. He has a tumor sitting in exactly the same place. So the tumor was missed with a mastectomy. Why? Because the specimen wasn't radiographed. So it's the little things. So it's easy to be good in 90% of the time. It's difficult to become good 98% of the time. So, and that depends on protocol. So that's where I say the MDT team must sit together. They must decide, how do we treat our patients? How do we avoid those things? And then everybody on that team needs to have a compact to say, we all agree to that same thing. And I think that is important.
One last question on that whole thing. To the surgeons, do medical aids pay for these? Because most of them, they're outpatient treatments. Do you get payment for 3 markers?
So if you are registered as an oncology patient, it's part of your imaging stuff. And as long as you have oncology benefits, they'll pay for it. They don't pay for the very expensive markers. They won't pay everything, or you have to motivate them. But once the patient has a diagnosis of cancer, they do pay for that, yes.
Add to that, I would support actually virtually everything that Etienne has said. You should actually come towards a protocol. I find it very important that the surgeon understands imaging and is able to perform basic imaging and interpret it in theater. And to add to that, Fatima has alluded to the multiple visits that we are receiving by reps, who all praise their different localization methods. We have actually arrived at a very, very basic and simple and cheap, above all, and reliable marking of our tumors. We insert donuts that are ultrasound visible. We can confirm real time in theater whether we have the donut in our specimen, and it's cheap. And this is something that is essential to us, and that should actually be essential to each and every unit. The plethora of localization devices that is in circulation elsewhere really indicates to me that the people don't know what they're doing properly. And I'm hanging myself here far out of the window, but that's the way it is.
I'll second that. Yes. Sorry, I'll second that. Yes, just in the sense that fancy things with all kinds of fancy devices don't necessarily work better. So, and I agree 100%. There's things that are simple to put in, that you can put 3 of them in, and that you can see on ultrasound, that you can find easily, and you can. I mean, we've even had specimens from the pathology lab that that have a whole big mastectomy of 1.2 kilograms, and now they have to find that thing. Then you can actually send the cassette down and they can X-ray. So it's not expensive. So, and adding that expense doesn't add any value in terms of what you can do for the patient. So I fully agree with that.
With her old, smaller, less invasive tumors with a pathological complete response, you don't need to take out a big chunk of tissue. So, I mean, this radar, the Scout, as you mentioned, I mean, you don't need to have 10 centimeters, 10 millimeters on that. You don't need to anymore.
And the surgery is still just a biopsy.
Yes.
The back is a biopsy, the surgery is just a biopsy of the bed. It's not excising everything. So that's the important part.
It's a very nice representative biopsy of the bed. That's what it is.
Yeah. So just to be you have to have clear margins. So if they're viable tumor, it has to be out. But in terms of if you find a complete pathological response, however big that tumor is, doesn't make any difference. And it's exactly the same principle as breast conservation versus mastectomy. Breast conservation without radiotherapy has a very high recurrence rate. And I think we'll find the same thing here in post-neoadjuvant. If you do that, let's say you do that, but you don't add the radiation, Rico will speak about that, we're going to have the same problem. So I think the question is, big margins on a complete pathological response. That I think I agree with Francois, that doesn't make any difference.
So, ladies and gentlemen, we're running slightly over time. I didn't think that surgery would generate that much discussion, but that's the hallmark of a very good presentation. There's an awful lot of discussion. So, Fatima, thank you very much.